As you know, thank you, Sarah. We do record these just so people know. If anybody has a problem, please let us know. We just thought it would sort of help for those that can't attend, so that they have the opportunity at least to look at it and see what the topic was that we've covered. But if, like say, if in the future people don't feel comfortable with that, please let us know and we won't do it anymore. But yeah, so I'm Gordon Borgstrom, retired from the BC Rural Centre, but still work with them a bit. And I live in Kamloops, and it's the traditional territory of Tecumseh Shuswap peoples. So with that, maybe I'll just ask, I'll start with Sarah, and then maybe you can just pick the next person and we'll go around.
For sure. Thank you, Gord. So my name is Sarah Sinclair, and I'm currently the project manager and digital media coordinator at the BC Rural Centre, as well as I do ECDev and community economic development and other business development in the Kootenay region. I'm living in Castle right now and have been for a long time. This is great to see everyone, and I'll pass it off to you, Naomi.
Good afternoon, everybody. My name is Naomi Larson. I'm the executive director here at the Chetwynd Chamber of Commerce. Been here about 7 years, been in Chetwynd for 16. We had a 5-year plan. Here we are. And I'm coming to you from the traditional territory of Treaty 8. And I will pass it off to, is it Pablita?
Hi, everyone. Yes, it is Pablita Naomi. Thank you for that. Pablita Thomas. I'm the ED over at the BC Hospice and Palliative Care Association. I am, head office is Vancouver, but I'm off on the island. I live in the beautiful Esquimalt on the island, and Saanich Nation of Coast Salish people, the Sahi, the Esquimalt, the Turslip. They're gonna kill me because every week one of the First Nations elder goes through all of the 9 nations name, and I always forget the last 3. But there is 9, and me and my beautiful children and my partner get to enjoy this beautiful island every day. So this is where I'm calling you from. Thank you.
Maybe we can go to Lorraine.
Lorraine, sorry, my little one is getting chips, so she caught my attention. Sorry. Yes, Lorraine.
Yeah. Lorraine Goring, coming to you from Fort Nelson, traditional territories of Treaty 8. Fort Nelson First Nation and Prophet River First Nations are signatories. I've lived here for 32 years. I'm on my 3rd term as a regional councillor. So bright sunny day here. It's only like all the way up to -7. So enjoying this spring-like weather. Thank you. And let's see, Joan.
Hi, everyone. Thank you for having us. My name is Joan Asali. I'm the program manager for the real-time virtual support with UBC Digital Emergency. We're taking care of the evaluation part of the real-time virtual support service. And my background is in international management and international development with the United Nations. So I'm very familiar with the work in international development and now with the evaluation. And we're here today to talk to you about the Learning Health System toolkit that we're developing with our partners, RCCBC, Ministry of Health, as well as the First Nation Health Authority. So very nice meeting all of you, and thank you for having us. I'll pass it on to Luella. I hope I pronounced it so correctly. Thank you so much.
Hi. Yep, that's about right. So my name is Luella Can. I'm Air Lakes Program Coordinator for Better at Home. And yeah, that's about it. So I'm new to the group, so still, trying to learn and figure out everything.
Thanks, Luella. Maybe we can go to Marian.
Okay.
Hi, I'm Marian. I'm located on Pender Island, and we're Coast Salish and a few other names that I slaughter, and I'm still practicing to learn. So I'm the executive director of the board that owns and manages this facility, and I have been here since 2014. And I'm looking forward to learning what I can today. I seem to be in deep waters a lot of the time today where I need an interpreter and a refresh on what I've just heard, a re-explanation. So we'll see how it goes today.
I share those issues, Marion. I know what you mean.
I started my day with a microbiologist conversation about mold. And I finished that conversation by saying, when we're back to speaking English, I have a question.
You don't mind? It's great. Lisa?
I assume, sorry, I was a bit late. So I assume we're just doing introductions. My name is Lisa Muir. I'm actually Chief Operating Officer for Pacific Blue Cross. We are a not-for-profit health benefits organization. We cover about 1.7 million people here in the province for the what I would call private health benefits. So extended health, drugs, medical equipment, dental. And I've been with Pacific Blue Cross for almost 48 years. So I was born here, grew up in the business, and very, very committed to participating and doing what we can to help improve the health and well-being of all British Columbians. And to me, this group is, I'm learning from this group, and I've already learned some of the challenges that people in rural communities face every single day in terms of not only accessing healthcare close to them, but in terms of getting even products and services delivered to them on a regular basis. So still a lot more to learn. I know that.
Thanks, Lisa. Very true. Kim?
Thanks, Gordon, and hi, everybody. Kim Williams. I work here at the Rural Coordination Centre of BC. I'm calling to you from the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh people. For those that aren't familiar with that, it's Vancouver. Tsleil-Waututh is the word for inlet. So normally when I'm in my home office, I'm looking out across Tsleil-Waututh and really appreciate learning and being able to just be there and connect in with the people that have taken care of that land for us. But today I'm in the Rural Coordination Centre offices and looking out at Broadway and Granville and all the busy traffic and the SkyTrain construction and whatnot. So it's a little bit of a different view. Happy to be here and to share any, I see Ray's on the phone, but anything that we need to add in and chat about from the RCC perspective as well, and even sort of the history for those that are new onto the group around the link sectors if we need to. And Lorraine, it's good to see you from once upon a time coming up to Fort Nelson and being there and meeting you up there. It's nice to have familiar faces.
Exactly.
I'll pass over to Hollis.
Okay, thanks, Kim.
Hi, everyone. So wonderful to meet you. And thank you so much for having us join your meeting. My name is Hollis, and I'm calling from the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh as well here in Vancouver. And I work with Joanne and for UBC Digital Emergency Medicine, and I'm a qualitative research analyst. So in our projects focusing on really hearing people's stories and collecting data through interviews and informing the evaluation of the real-time virtual support project. And we're really looking forward to sharing with you about this new initiative that Joanne mentioned about this learning health system toolkit.
Sorry, thanks so much, Hollis. I'm not sure I didn't realize, oh, it is, now it's changed to Ray's name there. Ray may be busy. I'm not sure Ray did this word. We just start.
Yeah.
Okay.
Yeah, hey Gordon, it's Ray. Just check, okay?
Yep. Okay,
great. Yeah, great. Hi everyone. My apologies for being a couple of minutes late. So it's Ray Markham, a rural GP in the village of Vermont, traditional territory of the Cape Name and some people, and part of the team with the Rural Coordination Centre of BC. Great to be here and happy to be listening. I'm on the phone because I'm doing a school run and kind of dodging in between the questions, but I'll be in as much as I can.
No worries at all, Ray. If we lose you, thanks very much I know you're really busy. So with that, yeah, Hollis, I'm not sure, maybe I can turn it over to you just to tell us a bit more about the research project and where it goes from here and what, if anything, our group can help you with.
Yes, thank you so much, Gordon. So we just have a short presentation to help give a bit of a background of what we're doing and how you could get involved. And then we'll have a time for questions. So I'll just share my screen. Okay, can everyone see these slides okay? Okay, great. I can also make them bigger. That's still okay? Okay, great. All right. Yes, so as I mentioned, this is part of the real-time virtual support initiative. And this is a funded research by the CIHR. So what we're going to discuss today, and it's about advancing health equity in British Columbia through partnership-based learning and health system model. And it's talking about a toolkit development. So I'm not sure what everyone's familiarity with real-time virtual support is, but we included a definition in case anyone is not familiar. So the real-time virtual support is RTVS, and it's a program using virtual care technology that connects patients and health professionals to services and support, as well as the goal is to help reduce barriers for accessing healthcare in rural, remote, and Indigenous communities. So this toolkit is a smaller sub-project coming out of this larger umbrella of real-time virtual support. And just talking a bit about our role of UBC Digital Emergency Medicine in the real-time virtual support. So we're involved in the evaluation and informing the implementation as well. And as you can see, there's many partners that we work with for real-time virtual support. So it's a very large project. And the toolkit, again, it's like just one aspect of it. Yes, Lisa, I see your hand is up.
So just a question, because real-time virtual support can happen for every healthcare, many healthcare professionals.
Yes.
Is this toolkit really for the primary care modules, or is it across the board for all healthcare professions? You know, chiro, ophthalmology, because I know they all have virtual care in their scope of practice under the health regulatory. So just trying to understand if this mainly public, or does this span public and private?
Oh, that's a good question. So from what I understand right now, it's mainly public. So real-time virtual support is focused on providing support for rural healthcare providers, specifically GPs generally, or also nurses working in those communities, and as well as providing them with some specialist support as well. And there's also patient-facing pathways in, for example, a First Nations patient could access care directly with a primary care provider, or also with a psychiatric support service. And so, yeah, does that help clarify a bit?
It helps, because I just want to be because I'm very aware, and I'm happy at the end of the presentation share a little bit of information. We also provide a virtual model, or a virtual care model, to some of our employers or individuals, but we are not allowed to provide virtual care to a physician directly. And that's because we would be in contravention of the Medicare Act, because we would be charging for a service, if that makes sense, and of using tools and all that stuff. So I wanted to make sure I understood what the scope of this was.
Okay, yes, thanks so much for clarifying. And just to clarify as well, so our RTVS is an already established program, and that's providing support for physicians as well as care for patients. And then the toolkit is, I guess, something that's coming out of it in order to help others working in similar area. All right, I can just go to next slide. So this is a bit about the objective of this project regarding the toolkit. So we're aiming to create a toolkit for others implementing virtual care in healthcare settings, emphasizing equity, diversity, and inclusion, and as well as to evaluate and improve virtual care services. And so the way we're going to create the toolkit is through a deliberative dialogue. So this would be a 1-day session, and right now the tentative date is May 2nd. And it's a facilitated discussion session that would be either on Zoom or in person. And we would work together to create actions and recommendations to inform the toolkit. And so currently participants include healthcare professionals, patients, rural community members, Indigenous elders, decision makers, health administrators, and we're really looking for input as well from community organizations and from linked sectors, which is why we are reaching out to this group. And so it's a part of the Pentagram Partnership Plus model. So just trying to incorporate everyone's voices at this discussion section and to work together in order to inform this toolkit. So yeah, as I mentioned, if you're interested, we're really interested in your input at that session on May 2nd, because we want to hear all voices in the development, and as well as, yeah, we recognize the importance of representation of linked sector members and your involvement in BC rural health. And so, yeah, how you can get involved is you could join and discuss your experiences on May 2nd. And it'll be, currently we're still working out the timing of it, but it'll be around 3 to 5.5 hours, and you have the option to attend in person or on Zoom. And these are just some additional details. We'll share with you documents and information before the session so you can get up to speed on what's happening. And yes, you'll be prepared for the discussion. And it'll be facilitated by a team member as well as an Indigenous elder. And we'll, yeah, share the results in the toolkit with attendees and also more broadly so others can use the toolkit as well. And so that's all I have. Are there any questions? And also, if you're interested, you can email me, or you can even put your email in the chat, or you can potentially even pass it on to the chair of the meeting, and we'll collect the emails. And then once we have the information, then we will send out invitations. And also, if you're not sure, that's okay. We can send you out more information and you can decide from there too. So.
Thank you, Hollis. I just want to add on the presentation right now and just explain the learning health system in a few sentences. The learning health system is an approach to programming where you implement and learn from the program that you are doing, and how we can continuously grow, and taking into consideration the context that you are working in, as well as the support from the partners that you are working, from the community, from the partners, and taking into context all these within the program itself. So based on from the RTVS has been implemented since April 2020. And taking that experience from our partners and our own experience, we're hoping to build this toolkit. And with the presence of the linked sector, the patients, the citizens, and other partners, we're hoping to inform how to make it easy for anybody who would like to implement the learning health system within their organization. So this is basically why we're approaching the linked sector, because we would like your input as well into in developing the learning health system toolkit, how to make it more accessible, more usable for anybody who would like to implement the learning health system within their own organization. And yeah, thank you.
Yeah, thanks for that, Joan. I think, I mean, a couple of things. One, yes, if between you and Hollis, if you could send Sarah more information about the proposed May 2nd meeting and you know, any other better group. I mean, I guess I would ask a couple of questions, sort of just following a bit with what Lisa was saying. I guess I just, like I happen to know from some other meetings with our CCBC, is it typically, you know, as rural people, when we hear the digital stuff, we're thinking more of just, well, you know, having a Zoom call with my doctor rather than an in-person call. Or, you know, in several of our rural centers now, they've set up specific rooms. So if I have to talk to a cancer specialist, I don't have to go all the way to Kelowna or Victoria. I can go in there and have a one-on-one meeting. I guess, just to be clear for us, sort of, are you then, as part of this evaluation, are you wanting to talk to doctors about how they feel about it and how it's working for them, as far as when a GP wants to talk to a specialist? about a case, are you also then looking for people that are patients that have had direct access to this or use of this and how they feel about it? And I assume it's more than just having a digital, virtual conference with your family doc. Is it more than that, or?
Well, the toolkit is basically, to answer your question, yes, we would like input from patients, from community, from partners, from the ministries, from different partners to input on this toolkit. But the toolkit is about implementing the learning health system as an approach to programming within the rural, remote, and indigenous communities. For example, if anybody who would like to start a program about virtual care, how can they use the learning health system to inform the program? What are the basics that they need to have, like having partners from the communities to inform the program? What is exactly the inequalities within that communities that we need to look at? What are the causes of these inequalities that we need to look at? How they inform the evaluation that we want to do, and basically using that approach to their own implementation, to the program they would like to implement, of the learning health system approach. So this is the toolkit about this approach. But definitely we would like the input from the communities, from the patients, from the ministries, from our own partners. We're working with the real-time virtual support as well to inform the building of that toolkit, to make it accessible for anybody who would like to implement that approach in their programming.
Okay, thank you. That helps. I think I was trying to also look at the chat box as we were going. Kim, really appreciate your offer to provide more information. I keep forgetting, like I've learned a little about some of our VTS, and I can't remember if it's been in this group or another discussion with RCCBC, but I think this group would probably be really quite interested in that. I'm not sure, Kim, if you want to take a little bit of time to discuss it now, but my understanding is some of the stuff that RCCBC was very good in sort of being able to address as far as some of the rural healthcare issues was a lot of times young new family physicians going out to a rural area not feeling 100% comfortable because they're having to deal with a bunch of stuff that maybe they haven't had a whole lot of experience with during their training. And that part of this, I believe this same program, gives them access to specialists and other trauma specialists in urban locations if they want to do a real-time consultation with somebody. And so there's those kind of things too that I think have really, really helped hopefully, retain and attract more people into the family medicine in rural areas. But Kim, did you want to give just a bit of a thumbnail of some of that stuff?
Yeah, it's huge to do a thumbnail, and I don't want to sort of take over the agenda on that, is why that I would, be happy to, I was sort of sitting there all of a sudden looking at presentations that I have over here. I don't want to do a presentation, but really, there has been virtual care in some form for quite a few years, mostly telehealth, and then some video. And then as we were sort of building out on that, when the pandemic hit and we recognized the potential impact to rural communities, rural citizens, especially as we were looking to Italy and Europe and seeing like the chaos that was happening. We didn't know what was going to go on. So we were able really quickly to stand up both some patient-facing and some provider-facing pathways. The patient-facing one led out in two ways by the First Nations Health Authority, so that because again, we're rural, so we're rural, remote, and Indigenous peoples. First Nations Health Authority, where any Indigenous person in the community in the province that needed a health provider could link in through this process. There, we developed it out with a medical office assistant, and they would link them in with either an Indigenous physician or an ally physician that was appropriately culturally safe and able to provide culturally safe and humble care, so that those people could could get in when they needed a physician around that. That's grown exponentially over the last 3 years. At the same time, the other patient-facing pathway was Heidi. So those of us in the province that are familiar with the 811 call line, where we call in to a nurse, and when you call into that, the nurses have an algorithm, and when they listen to you, they sort of have, you know, green, you're okay, stay home, you know, follow up with your physician another time. Red, you better get to the emerge right now. And then there's the yellow that, well, we don't, you know, could be, couldn't be, what do they do? And they went from 1,000 something calls a day, I believe, up to 6,000 calls a day when COVID first hit. And we realized that we, you know, we collective, large group of we partners, we needed to sort of help that situation. So a group of physicians, emergency physicians mostly, but general practitioners as well, joined, and then we called it the Heidi group. And so the nurses, when they would have a yellow patient, they could pass that on to a physician, and the physician would connect in virtually, either by video or phone, to the patients, talk to them with their physician clinical assessment, and make a decision whether they should go into the hospital or not. And thousands of calls have happened over these last 3 years. Many people appropriately sent into the hospital, many people diverted from hospital where they may not have needed to go especially when we were really concerned about the volumes going into our emergency departments. And then at the same time, as Gordon said, there was the provider lines. So again, recognizing in rural and remote that often there's only 1 or 2 providers in a community out there. And in the places of the First Nations nursing outpost stations, there's no physicians, there's nurses there by themselves. And many of these people, they're very competent providers, but it's hard to do care alone always. And if you're in a community, in a hospital, you're at Vancouver General or Kelowna or whatever, you can sort of pop your head down the hall and say, hey, can you just come and have a look at this, you know, second opinion, or just can we debrief this because this has been really stressful or whatnot. So we started what we called the Rudy line. It's an emergency line. It's Rural Urgent Doctors in Aid. All of our lines have names, like, because we talk about family and relationships. So some people get sort of crazy with all our acronyms, but we don't see them as acronyms. We sort of see them as names. So we have Rudy and Mabel and Charlie and Heidi and soon to be Rocky. So we have a family of supports, really, is what it is for people out there. So any provider, nurse or physician in the community can call through video using Zoom, you know, one call, and they can connect in with a provider. Yes, I will share the Rudy, R-U-D-I. And they would they'd answer and be there for them. And the idea is that those providers aren't busy doing something else. It's not to say that the providers in a regional center couldn't offer the help, but they're often busy in their own emergency departments or caring for something, whereas this group of providers is dedicated to answer the video now with that, how can I help you? What do you need? And not ever to make any provider feel less than by calling in, but actually more than, like, we're all in this together. How can we help? And what can I do to help you? And as Gordon said, for people that are isolated, for new providers, for people that are locuming in a community and don't know the resources, or for anybody that just needs another voice on the line, they can call. And that's, so our Rudy is sort of general emergency. We then added in Mabel, which is a mother and baby advice line. So again, you know, intrapartum, prenatal, postnatal type of calls by family physicians that specialize in maternity care. And then Charlie, that is the pediatrics, so the children help. That's where the C comes from. And those are pediatricians. And they're also supporting other places where there's not a pediatrician in every area in the community. They're sort of being that first on call. So it goes on and it expands out, but really there's the patient there. And to your question, Lisa, very specific to the public system of primary care providers and nurse practitioners, nurses, and then linking also in with specialists and specialized services as need be. Ray, I don't know if you're on the line, if there's anything in that quick sort of down and dirty that you wanted to add into that. 'Cause- He might not be there right now. Oh, you are there.
Yeah, no, I'm here. Somebody muted me, the host wise. So can you hear me?
Yep, we can.
Let me push *6 again to unmute. Excellent summary, Kim. The only thing I would say is part of the learning health system work is you start going somewhere and then you learn as you go, as I think we've just heard very nicely articulated. And so some of the points raised here around, does it involve, is it more than virtual, is it involving services and all those kind of things are great things to be bringing into the conversation. I think exactly the point of kind of this gathering and having these linked sector voices, I think we're getting a difference. I think it was Pacific Blue Cross is doing for uninsured services virtually, and then kind of is their way to integrate all of that into, so from a patient's perspective, it's fairly seamless and it's kind of not going here for this and here for this, or at least pointing that these things are available through these services. So that's, I think, as I understand it, the point of this this deliberative dialogue session is you actually start shaping up what the kind of things that need to be looked at.
And I am happy to send out some slides so that people have some of our picture graphics and that type of thing. And at a future meeting, if we want to dive into more of it, we can do that. And then that's sort of how Joan and Hollis link into us through the UBC Digital Emergency. They are part of our learning health system, helping us look and evaluate and grow and change as we go along. You know, in traditional things, you ask for some money, you say what you're going to do, you do it, and then you evaluate it to see whether you did it, and that's just sort of it. Whereas we're trying to constantly learn and grow and morph and change as we go. As Ray said, that's that whole thing. And part of that in our model of that is linking into this group, to our other citizens group, to our other providers to say, are we looking at the right things? Does this make sense? Yes. Okay, let's carry on. Now we have data, does this data tell us what we need to do? Is there anything we want to do different? So as this group sort of gets more solidified, it would be great for us to continually come back with this and other things. And that's the whole idea about the learning health system and the partnership pentagram work, is to make sure that other perspectives, not just health authorities and ministries or providers and health authorities or the universities by themselves do work, but that we sort of all come together with those different perspectives and iterate as we go along. Don't get me started because you won't shut me up.
Kim, could I ask a question then? If this is mainly a public program, who's at the end of all these lines? Do you have an infrastructure and a model that you've always got a pediatrician available to take a pediatric call, and I realize they could be throughout the province depending on where they need or where there could be available time. So it's like a huge scheduling system.
Oh yeah.
It's in the public system of saying, I could take this 20 minutes or out of my day.
We have a roster. So the First Nations Health Authority of the day, First Nations Doctor of the Day, they have their own process. And yes, they have scheduling and stuff. For our on-call services of support, yes, we have a roster, and we have our office assistant team that sends out the call 3 months in advance, who can go in here. And those providers are they're paid to be there, but they're expected not to be on call somewhere else. They're not expected to be out at Tofino surfing or whatever. They can be, driving their kids to school or whatever, but they're available to answer the call and be there. The challenge often in a public system is it starts to get about more. How many calls? It's all about the numbers. And for us, it's actually we wanted enough numbers to make things viable, but we don't want so many numbers because sometimes these providers are on the calls for a couple of hours. If they're walking somebody through, waiting for a transport team, or they're helping a nurse do a resuscitation in an outpost, whatever it is, they need to be there. So we have systems in place for backup. If they say, I'm going to be on here for 2 hours, they have people that they know that are going to be on backup. But we have pediatricians, ER and general physicians.
and based on the challenge I said earlier, is private sector insurance companies were offering this as an add-on benefit that employers could add or to their benefits. But we're starting to see challenges. So we actually had to take a lot of the service we offer away to the private sector, and all, people could still use virtual services, but it's, I believe it's a nurse practitioner that is triaging the call, and they get access to like a nutritionist but nothing out of the public healthcare system. So I would love to understand more about this, and how can the public, we have lots of members that are in rural communities too that don't have any access. How do we promote it for you, even knowing it exists? Because I had no idea it even existed. Sorry, I'll stop now because
that's okay. And it's just interesting. So the part that we do at RCC is the peer-to-peer part. So this is the providers helping each other. And so it's not a public facing, like not a citizen patient facing thing, but it's good for folks to know that if they're in their local hospital and their nurse practitioner or physicians by themselves, that there's something that they can call out for help. So don't be afraid to go, because there's help. Looking up at Lorraine, what we've been, the other sort of next phase that we've started with this is in communities where, for whatever reason, there's not enough physicians for a night or two or a weekend. And so we've actually been able to put into the roster to say, like in Fort Nelson, our Rudy physicians will be the ER physician virtually with the other in community, not all by themselves, but there's an in community physician that maybe actually can go home and go to sleep for a few hours rather than being on call all night and then doing their clinic the next day. Because in rural, there's not the hospitalist that just does the hospital and the primary care just does primary care. They're the same people. So they have to be in the ER all night and then go to the office in the morning. And if there's not enough of them to sort of, count each other off, then it's not sustainable for those poor providers. So right now we've got the extra lines so that on certain nights in certain communities, we can't do it across the province, of course, it's sort of a negotiation thing going on, but that the first call will be one of our Rudy docs and the nurse there in the ER, a small ER. It can't be a huge ER. It has to be a small ER. We'll connect in with Bryden, who maybe is the doctor that night, and they introduce them to the patients that are there and the nurse and the doctor that's going to go home and go to sleep with that nurse in the room, knowing that if somebody comes in needing all hands on deck, they phone the physician that's at home. It's not like they don't call them. They would call them and say, no, we need you. And in the meantime, Bryden on Rudy, he can be calling emergency transport or ordering some blood from another community, whatever it is they have to do. But they sort of work together. So it keeps, again, that's that learning health system. We started off with one piece and then we saw something else and then we saw something else. So we just sort of keep morphing. Yeah, it's pretty exciting. Pablita, oops.
Oh, you go ahead.
Yeah, no, I think all this sounds really quite interesting, and I appreciate providing examples. I'm very much more of a give me an example kind of learner, so I know how it integrates within the community. So I appreciate all the examples for sure. I guess two questions. One question would be that it's really nice to hear that there are programs that have built to support the primary health care system. But I do feel that when we talk about hospice and palliative care services, because we teeter-totter between primary and community, there tends to be a bit of a miss in that area. But I want to know from you, Kim, has there been discussion about looking at more of a specialist in terms of palliative care physicians or palliative care nurses to be part of that? Because a lot of the times, from what we've been hearing from our membership in the rural and remote communities, they're usually the only ones there that are providing any sort of services when it comes to palliative care supports, grief and bereavement supports. So I just wanted to know if there's been any sort of discussions. And then my other question would be towards Joan and Hollis, I think is how you say your name. I apologize. I would love to know how, what kind of information, when you say you are in the midst of reaching out to different organizations, ministerial level, to get feedback to see what is amiss, what exactly are you looking for in terms of information, and what does that look like? And just a little bit further information on this May meeting that you're talking about, because I think there's a lot of our community partners and hospices that would really appreciate having that their bits of experiences and perspectives be included in that.
I'll jump in and answer your first question, Pablita, and then pass it over to Joan and Hollis. There hasn't been palliative care sort of linked in to call our providers, not to say that we couldn't do that. So we should talk about doing that. At the same time, the other piece that I didn't talk about was what we call the quick reply pathways. So there is a rheumatoid, a rheumatologist, a dermatologist, some mental health. There's about 8 different sort of specialized services that any of our providers, they're linked into us now and they're on our Zoom world. But if any of our any provider in BC needed to just call them they might not answer immediately, but they will video in. They all sort of have different times. I'll call you back in a few minutes. I'll do, and there could be even, I'm just brainstorming with you, there could be palliative at that end, that somebody in community that needed palliative support could link in that way, as the same way as if somebody was providing palliative care and really needed a GP or an ER specialist to just talk to it, wherever they were, to say, can you help me with this? There's opportunities for that. So I think we should link in. We should talk.
Yeah, sounds great.
Yeah, good. I'll pass you over to Joan. And then I also know that, where'd she go?
Yeah, I think Lorraine had her hand up.
Lorraine left. Oh, there she is. She's up there with the little thing, but she had her hand up too. I was going to say, I don't see her face. Joan.
Yeah, thank you, Kim. Yeah, just to add on what Kim had mentioned right now about the service, the RTVS service. The RTVS service is an amazing service that for rural and remote Indigenous communities. But the learning health system is about also being aware what's happening in the community and what services are given to the community members. And in order not to duplicate effort and just work together towards health equity and reaching the outcome that we want to reach within those areas. So it's not about overlapping or taking over. It's about complementarity and working together in those communities. So that's the beauty of this approach. And it's a learning approach. So bringing those community members, bringing those organizations to be part of the program as well. So just Pablita, on what you have mentioned right now, and the agenda, we're still working on the agenda, but before, we're looking at the link sector to inform this toolkit, and some background material will be given to the participants that will include some information about the learning health system and others about partnership, but the discussion will be mainly around their experience in terms of access, equity, partnership, what tools that they would like to see within this toolkit. It will be like a toolbox that they can go into and inform their program, what exactly they need in order to work in that community, how to set up the basis in terms of working in that community, what to look for. So we'll be giving the participants all this information before and having the discussion on May 2nd, tentatively on May 2nd. It will be an informative, looking at their experience, looking at their knowledge, and working in those areas as well to inform the toolkit itself, to make it more easy to use. I hope I answered your question. So we're looking forward to your participation in that day, on that day, and feel free to reach out to us. I think Hollis, Sarah does have our email, but we can include it also in the chat for the participation.
Thanks very much, Joan. I really appreciate that. And just quickly, I'm not sure if it's only me, and tell us every once in a while, it seemed to have been fine the last 5 minutes, but before people were either freezing or cutting out a wee bit on my internet. I'm not sure if other folks, but hopefully it's settled down to allow us to talk. I'm not sure, Lorraine, you had your hand up earlier. Was there?
I did. I was just going to share Fort Nelson's experience.
Oh,
with-
sorry.
No, it's all good. You did a much better job than I could have. Yeah, it's I just would add that our doctors are so happy to have it. Over Christmas, we had one doctor left in the community for 10 days, all on his own because the other doctor couldn't get out of Vancouver. So with all the travel chaos, so they have been using it quite regularly because we are short 2 doctors right now. So to have this service available has been phenomenal for us and has definitely kept our emergency room open. That those of you that know, we're very far away from anything. So yeah, it's just a bonus and very, very grateful to have this service in our community and would highly recommend it.
Yeah, thanks, Lorraine. Appreciate that. Is there anybody else wanted to raise a point? If not, one of the things I'll just throw out there, I'm not sure this is the appropriate sort of forum for it, but the other thing I hope is at some point down the road, I mean, I think that obviously, you know, the digital stuff has a huge, it's already working, I think, extremely well in a lot of cases in rural communities. And I think people are deeply, deeply appreciative of it. I hope at some point too, that we might be able to look at things and say, are there, you know, I think a lot of times in rural communities, what I hear is, well, we don't have some of the lab support services or other things that allow more diagnosis work to be done in situ, that people will have to travel to bigger centers. And I think everybody sort of understands that. But I think there are cases, again, I'll just use some personal experience I had with my older brother is, I'm hoping that as we go along, we can identify things that are perhaps a little bit more common that people are having to travel for, where there could be an additional technical fix. And what I'm thinking of is, I had an older brother, he's got a pacemaker, spent 5 or 6 nights in the hospital in Cranbrook while we were trying to get him to Kelowna. He was in Kelowna for a couple of days in the cardiac unit, and then a technician finally came in, slapped something on his heart and said, oh yeah, the battery's dead. It's those kind of things where I would wonder if there isn't a possibility if the hospital auxiliary could buy that unit. They had it in Cranbrook, maybe you still need the technician in Kelowna to read it, but it could have been done days earlier. And I just think that, you know, this technology, sometimes if there's a way that we can also think about, well, what other equipment maybe can we put in smaller rural communities that help with quicker diagnosis and avoid people having to travel. I mean, in his case, he still would have had to gone, but you know, I just think it's something that could be done a lot quicker. And I think it's a little bit of a, you know, technological add-on. And I'm not sure, you know, if those kind of things are looked at, or there's mechanisms to be able to say to hospital auxiliaries, you know, this would be a nice piece of equipment if we could have it, and we can work it out now that we have a big enough, you know, pipeline of technology that people in Kelowna can still, the technicians can still do their work from there, from other locales. But anyway, that's just one story that I would sort of throw out there.
Leads us into the conversation of drones as well, which we're also, that's a whole other conversation for another day. Maybe John Polovich wants to come and share that with you, because that gets in there as well.
Exactly. I've noticed a couple of people have just joined us a little bit late, so I'd like to offer an opportunity. I'm not sure, Roger, is there anything, or Joan or Jane, sorry, that you guys joining in? Sorry, sort of what we've just been talking about is sort of digital medicine and how it's working and how it could be improved in BC.
No, actually, Cam, I sorry for being late, by the way. And I caught the end of it, which I found really interesting, but and I think we talked about this at the last session, I raised it, but I'm becoming to see technology as the evil guy these days. And from this perspective, you know, I think when I first got involved with your group, Gord, now I think, and that was about the time the events were in Vancouver, which probably now is 4 or 5 years ago, maybe more, a couple of big events. And everything was, the focus was to get more technology, from telehealth to all the things that brought resources into rural communities where we didn't have either people or we didn't have expertise, and to allow you to sort of do more at home. And for me, that was important then. I think it's less important now. I think there's a tipping point in the delivery of healthcare across the province of BC where we finally have to, actually everywhere, admit that this is no longer a technology issue, it's a people issue. And we're now using technology as a crutch to stop us from trying to fill it with people. And my view of the world is now sort of shifting to every now and then you put things in the top of the priority heap. For me, technology is probably not at the top of my heap at all. I'm not against it, and I think we can continue to expand it and make it use good. But if we focus on that, I think we give governments and others a reason for not doing the things they need to do to fill it with people. And we just have a crisis of human resources, which, by the way, is across every industry. And any of you that live in Chetwynd, Fort Nelson, know that you live in parts of the world where there's jobs looking for people, not people looking for jobs. But we really have to focus on growing the number of people that are actually working in this field, whether it's palliative care, the whole spectrum, because that's where the focus needs to be. And the technology will evolve, but at some point we can't continue to think that it's going to be the crutch that's going to save us.
Totally agree with you, Roger. It can't be. I think there's opportunities for it to go hand in glove, but it can never be the replacement. Even in the example Lorraine and I are giving about Fort Nelson, it's sort of like the last straw. And isn't it sad that we have to have virtual to support the providers that are there when really what we need is providers there? So I think it has to happen at the same time. One of the interesting things that we've had conversations about is the virtual to support the education, because what we hear in education is that you can't have somebody training as a specialist in whatever, or a family physician, whatever, in rural, because there's not enough mentors, or they don't have that service. There might not be a physio service in Caslo, and I don't know whether there is, I'm just making that up. So they say, well, we don't have enough places to send people. But if we had the person going to Caslo and have their mentor and their educator supporting them virtually, then it expands the opportunity to build the workforce and through the education in a different way. So 100% agree with you. I think that it doesn't replace in person, but it certainly supports those that are there out in our world right now, those that are out there alone. It's keeping them there.
Yeah, if there's one thing that COVID taught us all, it's amazing how much we can do with video, both as a communication tool, as a teaching tool, as a commercial tool. I mean, it's become, people are certainly getting back together, but video like these haven't disappeared. They're now just part of the mantra of connecting. You can do a lot with it, and we don't use it nearly enough.
Yeah,
for the education side, it's a really fabulous tool for that.
And then the other piece is, and it's one of the conversations I was in earlier today, there's still not equity of access to bandwidth across rural BC to even benefit from what we're talking about. So that's a whole other, issue and conversation that I think we need to, that we as our team keeps pushing. I mean, obviously we're in health. It's not necessarily a health responsibility, but it's a health problem. Along with education and everybody else. But those of you that live in rural, just even Gordon saying he's cutting out all the time. Sometimes my city internet cuts out too, but there's places that we can't even help with virtual because they don't have the technology, or the Elon Musk hasn't landed in their neighborhood yet.
Exactly. Exactly.
All right, I'm going to back off now, Gordon, and let you get back to your agenda, because I totally waylaid your
Not
your
at all.
meeting.
Not at all. I'm hoping I think Hollis and Joan find this useful. I do. Marion, can I just ask, coming from a community health center perspective, what do you think on this stuff?
I'm my head's whizzing. The first thing that comes to me is we can't even have a successful cell phone call in our community health center. The call gets dropped from between my office and the treatment room. So if the docs are going to the computer to look something up, the patient, they want to stay with at least within sight of the patient because they're here by themselves often. Weekend and evenings for sure they're by themselves. And the call will drop. So if they're on the line to some virtual support or the transport team or whatever, that's the end of that. So that's been my battle, and I've lost with TELUS. They can't do anything and they've walked away. So that's the first thing I'm thinking. The second thing I'm thinking is, we do our high speed is slower than my low speed when I lived in Calgary 10 years ago. So some of this virtual becomes a real challenge, and it becomes an access issue, certainly for patients, because we are the flip phone gang on Pender for sure. That's as predominant as any other kind of phone, and that's sometimes an affordability reason for just having a flip phone, and sometimes it's just comfort that any other form of technology is overwhelming or too expensive. So that's the other thing that's coming to my mind. The third thing is I'm sitting here thinking, crap, we have at least one weekend a month where we have no doctor available, period. And so I'm thinking, at least a DOC that was virtual would be better than Zip. So I'm trying to figure that out in my head. So it's no doc. So we don't have somebody that we have a doc calling to another doc for a consultation or support. We have 911 and off-island transport, I guess. Pretty much. Does that help you at all, Gordon?
It does. Thank you, Marianne. And I mean, I think that's very similar to what Lorraine was mentioning, is that, and for a lot of us, right, that even if we have a hospital, the emergency room quite often is closed. So,
yeah. And we're no hospital.
Yeah.
We're an urgent treatment center with no backup lab, no x-ray, all of those kinds of things. So it's real cowboy doctoring sometimes, for lack of a better word. You have to go by your skills and your gut instinct and your experience, because you don't have the data to help you decipher what you want. So it's pretty amazing what happens.
Exactly. I thought Pablita brought up a really good point about, because I'm thinking, a lot of times too, we think about very specialist care that we're missing. So certainly palliative, very extensive, or psychiatric in rural areas. But I'm also wondering, Luella and Jane, I mean, both of you work a lot with seniors in larger regional context areas. Can I ask Luella first, and then maybe Jane? I mean, listening to this discussion, what do you guys see that, having worked with your client groups, that you could see that the digital stuff maybe could be a little more useful or not?
Well, the digital works really well because a lot of clients are just people in the community that have to go to a specialist. They have to drive, 2.5 hours to 3.5 hours. So just for a quick 5-minute phone call, it makes all the difference to have that phone call. So that's really, really helpful. And we can thank COVID for that, because that's kind of when it all started. And then we're actually really fortunate because we are a small community, but we're the larger community in the area. So we have gotten to keep our hospital, and our ER has, improved, and we have a lab, we have x-ray departments, small physio department, so we're really fortunate that way. And we've been in the position where we haven't, had enough doctors and nurses. And right now, I believe, I think we have 4 doctors, and I don't think we've been without a doctor like on call for a long, long time. And we did have the challenge of nurses, but now they're bringing nurses in quite regularly from Revelstoke or wherever they want to come, and they have a list of Airbnbs, whatever, that they can book into. I'm not sure how that all works, but yeah, so they come in, they do their shifts, and then they go back home. So we're looking pretty good. And when we had the shortages, we started out with the community housing. So our the doctors actually bought a home in town. And then that was kind of a way to, you know, kind of lure the doctors in because they would have free housing. And it did work because it did bring up doctors. And now we seem to be, you know, getting doctors and keeping them. And we've had 2 doctors leave, retired in the last few months, and we've been able to recruit more doctors. We lost our community paramedics. That was huge. But we do have a social worker nurse out of the hospital or out of the doctor's office. And then she's almost, you know, she's not as handy as a community paramedic because she didn't have that kind of training. But she is another person that we deal with a lot. With
Sorry, Luella,
our clients. Pardon me?
Can I just ask, the community paramedic, did the person just leave or you lost the position?
I kind of didn't even know what was happening. All of a sudden they were gone. And then I did see one of them, and I think it came to a funding. I think just more money for what they were doing, I think. So I think they cut the program because of that. I don't know, like it was just kind of a place where I couldn't really ask too many questions. But yeah, I think he said just something about it's too bad that, you know, they couldn't have given more money towards it. So I'm not quite sure what happened. But it was pretty successful when it was here.
Well, yeah, and the reason I asked is I remember several calls ago, Lorraine, we were talking about the community paramedic program because I didn't know it existed till a year ago.
Yeah.
Showing the video, and then that's what Lorraine mentioned is, you know, they trained a young individual to do the job in Fort Nelson, and then he got hired away, and there was no plan B to backfill that position.
Yeah.
It seems to me that, yeah, it seems like it would be a very, very successful program. So,
yeah, it was. It takes a lot off the doctors.
We finally got another one a year later. So yes, it's hugely successful. We've had 2, 1 left, but anyways, we're back on track. So I think it's about 18 months since we got off track, but it's just amazing what the community paramedics can do. So I would highly recommend for anybody, if you don't have one operating in your community, to advocate for yourself, get out there and get one. We have in our small little community, we have what they call a weekly social group at the walking track. She has 30 plus people there every single week and do the health checks. She goes into the care home, does the health checks 2 to 3 times a month. So that takes all that pressure off of our local doctors and goes out to the reserve as well. So yeah, it's like an amazing program if you can get it in your community.
Exactly, and keep it. Thanks, Lorraine. Just want to, and sorry, just very quickly, in case some people may have missed it at the very beginning, when Luella was talking about them being very fortunate with their 4 doctors in their hospital, that's in the cusp in the West Kootenays. So good for you guys. Jane from Vancouver Island, how are things there?
Can you hear me? The plumbing crew just arrived, so I'm trying to use a headphone. Yeah, okay. This is such a multi-factor thing, isn't it? Speaking about community paramedics in Tassos, what they did, you know, is the community paramedic there has engaged in a program of training up a whole other people who are on call, on standby, so that they now have coverage, which is really great news, because you're right. One person leaves, if you're relying on one person or even 2 people, it's kind of doesn't work anymore. I guess my comments around seniors, since I am one, would probably be 2 things. First of all, we can't live without the virtual, but we can look at it. But there are definitely folks that I deal with and work with that it doesn't work for them, right? It doesn't work for them for a myriad of different reasons. It may be hearing, who knows? It could be any number of reasons. So that kind of really talks about how to support them to have the conversation. That's one piece. You know, the second piece that I see is I agree. We are so thin in the ground right now. If you go up to Port Hardy, some of you may have seen I can't remember if it was Globe and Mail or which, what, the one person left standing in the emergency, and that's for 3 communities, right? That's for, major size communities, Port Alice, McNeil and Hardy, essentially is saying, help, I need innovative solutions. Right at the moment, more money for physicians and doctors is not going to help us right now because we don't have people to pay. And they're walking away for other reasons. So I think that it's so hugely complex. I'm just sorry I missed the first part of this. And I've took down the email addresses, and I will be contacting, Hollis and Joan to say, can we have a conversation and you can bring me up to speed. But I never know where to turn with this kind of thing. I mean, can't live without the virtual. I love the ideas of the back end pieces so that in the front, we can actually have a person. Because for many seniors, it is about connection. It's about a person sitting in front of them, not about a piece of technology or a telephone or any of that stuff. It's about, hello, somebody that is right here connected with me. So we have to look at, how we use technology in effective ways. And as to the, bandwidth and all of that stuff, holy crap, we have communities that, well, I'm still living with the fact that Gabriella lost all of their landline connectivity, and then their cell service got restored after 2 or 3 days to just a few little pockets. So we had a whole island full of people for 10 days disconnected. So there has to be more attention paid to that fundamental infrastructure. And, and so for me, I'm really interested in going out and trying to figure out how to light a fire under that piece of it. And because we can have all of this stuff, but if we don't have the infrastructure to use it, it's a waste of time. And I certainly know over in Alert Bay, we have one side of the street that's wired and another side of the street maybe that isn't, right? So they don't have any connectivity on one side of the street. This is an issue. And now I'll be quiet because I can talk far too much and I missed the first part, so I don't even know what I missed.
Not at all. No, that really helps, Jane. And I think, I think hopefully for Hollis and Jane, I think that as Roger brought up, it really is sort of this issue as he says, got to be very careful, as useful as it is. And obviously we're not going backwards. The digital is always going to be there. But yeah, if we rely on it thinking it's going to solve some other problems, it's not going to solve everything that we need solved. You still need people behind that technology or using that technology, hopefully. So, Naomi, is there anything, you've been a bit quiet from Chetwynd's perspective? I remember you mentioning once that having to do a long trip to go see a specialist, and sometimes
I did. Yeah, our issue here in Chetwynd is that we're good with doctors finally, which is wonderful, but we have no nurses. So our hospital is on diversion quite a bit. We don't hear about it too much. I notice I watch the news. I see when, Port McNeil or Port Alice or anything down on the coast goes on diversion, and we never really hear anything about up here. Actually, last year, every time our hospital went on diversion, I emailed Global. And at one point we were on diversion for more than, 20 times in less than a month. And those diversions can be just overnight, or they can be a couple hours, but and living up north, it's an hour to Dawson Creek, just over an hour to Dawson Creek, 2 hours to Fort St. John. Really depends on what the weather is like. Those can be extended substantially just due to the weather. So you can be risking not being able to get to your own hospital because it's closed, but then you may not make it to the next hospital. So yeah, and I ended up having to we don't have specialists around here either. I was air backed out to Vancouver and spent a week and a bit in Vancouver on my own with a massive surgery in the middle of winter where my family had to stay back. So there's definitely some rooms for improvement, especially when it comes to rural healthcare. Absolutely. And we touched briefly on internet and connectivity. And connectivity is a huge point when it comes to just about anything in our lives these days, but including healthcare. I live 15 kilometers outside of town. I don't have cell service and I don't have internet. So you keep your landline and you hope that that it's always going to work. So we were told 2027 the earliest is we might get cell service and internet, but that has a huge thing because a huge aspect as well, because when it comes to, like we were talking earlier about video and healthcare through apps, etc. I'm on satellite, a snowstorm or rain or wind can affect that.
Exactly.
Pretty good. Can cut you out pretty quick. So there's work to do, but we can get her done eventually.
One thing
I always like to be optimistic. I'm like, let's do this. We can do it. So
exactly. Well, rural
One-
persistence.
yeah.
Right?
One thing I forgot to mention was the ambulance service. That's where we're really struggling with that. And we actually did have a really tragic incident because ambulance was like 2 hours and the person did die. So that's
we had that as well a couple months ago.
Yeah.
And they were right downtown. The ambulance is like literally less than a minute drive away, but there was no ambulances in town because one was doing a transfer and the other one was in Dawson, and we lost somebody.
Yeah, and these people were probably 5 minutes from the hospital, but it wasn't a good situation to take them to the hospital by themselves. And then after an hour, they did attempt to, and then he ended up actually passing away in the vehicle. And then they got to the hospital for some reason. I guess it was a Saturday afternoon and the hospital was locked up. So they had to use the intercom, and because they're in that panic mode, they, forgot about that. And so it was a really, really bad, sad situation for them.
Exactly. Yeah. And I think you think of, how short of paramedics they are at the best of times. And then I think, people don't think of that as soon as you have the diversion. Well, then that means that the limited ambulance service you did have is a lot of times out of town, unavailable. Sometimes too, it's again, somewhat off topic, but not really, is unintended consequences. I think too that when the advanced life support was first created 4 or 5 years ago, or more than that, I guess, with the ambulance service, my understanding was part of the reason it was created was so you had a higher level trained paramedic, recognizing in rural areas there's much longer transportation distances to the next level of care. So the idea was, and then what happened is they got established, but somebody had, in their wisdom and the ambulance service decided their call levels weren't high enough. So all those people should be transferred to urban areas where their skills are being used more. Well, you just gotta go, well, hold it here. What about us? That was supposed to be created to help us. Now you've moved them out of town. Like, what the hell?
Yeah.
Anyway, sorry, my tirade.
No, that's okay.
We have a trade show coming up, in our emergency health services actually putting a booth in to try to recruit paramedics and try to get more community involvement happening. So hopefully we're able to attract a few more paramedics to our area. We finally have a couple of full-time ones, which is great. We never had that before, but they're run off their feet and exhausted.
Exactly. Well, I'm conscious of the time. It's 4:15. I don't want to cut off the conversation, but I also know that people may have to leave. Can I just ask, did anybody else want to bring anything up? Just to let people know, I mean, our next meeting is scheduled for Wednesday, March 15th. One of 2 topics, I'm not sure which yet, so I'll wait and I'll let you know once we get the speakers confirmed. The other thing is, I'm hoping I can ask everybody just to give a bit of thought, and then please send me just an email. The RCC BC has been kind enough and has given us a bit of financial support that, as Roger mentioned, we all came together once before COVID hit in January of, I don't know if that would have been 20 or 21, I can't remember, but whenever, before COVID, just before COVID, and we all met in Richmond for one day. As Richard said, as Roger said, I mean, we're so used to all being on Zoom calls. On the other hand, it is kind of nice to get together in person. The way we organized it that one time is you know, the reality is for all of us, the easiest place to get to is Vancouver, because a lot of times that's the only place we can get a flight to if we're flying. So what we did is organize it so that people could do it. Most people could do it in a day trip, where we would start sort of 9:30 and make sure that you're out by 5 so you can get back to the airport and get your 6 o'clock flight, since most flights in seem to, you know, leave between 7 and 9 and go out between 5 and 7. So could I just leave that with you to ask if people would be interested in giving up a day? I'm guessing, again, because of, you know, hopefully the weather and travel, you know, it'd be probably April or May. And what kind of topics you guys would like to discuss to make sure that you feel it's worth giving up a day from your day job, I know. And for a lot of you, I know it's a lot more than that one day, because it's probably another full day at least of travel, if not 2 days, just to get there and back. But please give that a bit of thought, and then just reach out to me about what your thoughts are and what kind of topics. You know, certainly one of the things I think is, I really appreciate Kim giving us a bit of an overview, that, you know, my sense is there's lots of really, really neat stuff that the RCCBC and the Rural Docs have been doing that most of us don't really know a lot about. So I think even just being able to spend an hour sort of getting up to speed on that might be helpful. And then whatever else people would be interested in discussing, please let me know. Anything else?
If this was an in-person thing, would there be an opportunity to perhaps bring somebody from the community, like an invitation to a mayor or a counselor or healthcare person?
I mean, I guess we could certainly talk about that. In the past, what we've done is just members of the actual group. But yeah, that's certainly, I think we could talk. I mean, when we established the group, and Naomi, is that there was this sort of sense that I think that we're really hoping to have people there as individuals. Everybody kind of brings their own background experience, right, to it, but they're not really there to represent any specific interest, if you will. They're just there as an individual and speaking that way. My sense is, though, that probably what might be useful is we could certainly ask a couple of individuals. The other thing is that through this group, we're linked to a bunch of other groups. So for example, Jane is on the board of the BC Rural Health Network, which is doing a lot of advocacy work. I think that there's this new mayor's initiative. I'm not sure, Jane, how much, hopefully they're talking to you guys. But, you know, a lot of the mayors are getting together just about to talk about the emergency room closures. So there's a lot of advocacy going on amongst local government as well for very specific issues.
That's true. Although my primary role at the moment is DEIB. Are we only hearing from mayors that are older, white privileged and whatnot? Or are we really hearing from everyone in residents and community? But yes, there's a bunch going on. It's a very lively sort of organization to be, you know, attached to right now. And if you go anywhere near it, someone will try to recruit you. Just so you know, that's what happened to me. Okay.
Exactly.
I just, for those that haven't been with the group a long time, just sort of put that picture back out there again, that I said at the beginning, that often it's, you know, the policymakers, the ministry and the health authorities that make health decisions, or academia off by themselves or whatnot. And the idea with our Pentagram Partnership Plus, which was actually developed for the WHO many years ago, and looking at medical schools, social accountability, and we've sort of spread it out for health systems planning and accountability. We added in there was the 5 sectors of policymakers, administrators, citizens and communities, academia, and health providers. And it was Ray who was on there with us that thought we need the link sectors. The link sectors being that non-for-profit and industry that are impacted by health or impact health in rural. So we've added that group on. So it's a perspective that we look at. And so by having Gordon, his team, lead out this group, we look to you for that link sector perspective. And there will be provider table perspectives, and there is policy perspectives, all sort of going. So when we want to talk about something, whether it's RTVS or nurse recruitment or transport, anything that we're talking about, then we, you know, want to link in and get that sort of link sector perspective. So just saying that in response to inviting citizens or others to your link sector meeting, there's opportunities for those perspectives to be collected elsewhere. So when you come, it's not thinking about your coming, Naomi, bringing Chetwynd's perspective. It's more your perspective as someone living and being part of the Chamber of Commerce in that community. And others will do that as well. I just wanted to sort of frame that out so it makes it a little bit clear.
Yeah. Okay.
Yeah, thanks, Kim. Very good point. Well, folks, and Sarah, was there any, I'm not sure, like using this technology, I'm hoping you were monitoring the chat and we can respond to any of that. And does it disappear when we go away
No.
or? Okay, you've
Well,
got
it downloads. I keep a copy of it in a file just for email addresses and stuff, but I will have to go down to get the fast Wi-Fi so I can upload this and and I'll send everybody the link to this and the slides. So Jane and Hollis, if you'd be willing to send me your slide deck, that'd be awesome. And I'll just create a little package for everyone moving forward to send it out. And it'll probably be a day that it takes to upload.
Okay, great. Well, thank you. We'll do that. So like I said, we'll be in touch anyway about March 15th. And then if you don't mind, I probably will, I'll ask Sarah to send out a doodle poll in a week or two, looking if we might find a date in April or May that works for folks to all come together in person. And like I say, if you don't mind, please send me your ideas of things you would like to discuss or presentations you'd be particularly interested in hearing about. And to Hollis and Jane, thank you very much for your time and patience and presentation.
Thank you.
Thank you very much.
Okay.
Thank you.
Goodbye, everybody.
Bye.
Bye.